weekend because the Steelers had won Thursday, so I wasn't stressed out. And I'm still alive in my survivor pool. 2 entries. Houston pulling it out at the death. Oh, God, he's good. What? Oh, the Giants are awful. I mean, when I knew the Houston game was going to be close, but he's watch out. Yeah, go figure. All right, everybody, welcome to our world. All right, we're going to finish this, and I'll let you go on your merry way. It's all right. The small intestine, or as I like to say, intestine. I always say intestine. So this is the big player. So far, the stomach is mostly mechanical with a little bit of chemical activity. Mouth is mostly mechanical, a little bit of chemical activity. When you're talking about chemical digestion and absorption, this is the player. The large intestine is non-essential tissue. You can live without it. But your small intestine, you want to part with very little. Thankfully, we have a lot. These numbers are wrong, roughly, as you will see subsequently, so I don't rely on the PowerPoint. The small intestine for most of us is about 20, 21 feet in length. So this 7 to 13, maybe 1 is 7 and 1's 13, I'll buy that. So it starts at the pyloric sphincter with the start of the duodenum or duodenum, at the ileocecal valve, which is that narrowing bigger part at the pyloric valve, and then ends at the narrowing as it opens into the cecum, which is the first section or segment of the large intestine. It's the only one that has a specific name. Okay, and so its diameter, as you can see, comparatively is 1 inch to 1.5 inches in diameter, where the large intestine is probably about 2.5 inches. So it's a good maybe 2.5 times greater in diameter. The duodenum, again, when you see retroperitoneal, to me, those are stable points. Why this is retroperitoneal? The stability of the common bile duct. That's an area, when you have something that's retroperitoneal, it's doing functions where excessive motion conceivably could be problematic, at least in my eyes. So as you can see, it's less than a foot, and it's this small circular around the head of the pancreas, yet it has, with the exception of the valve, which is the only one that's there, it has all of those features that we will cover in the anatomy. And then as you can see, look at 8 and 12 feet, so we're over 20 feet. The jejunum and the ileum. Notice this ileum, and you got to be careful on an exam. You can ask me if I meant ILIUM, the bone, or ILEUM, the anatomical structure in the gastrointestinal tract, but you can't do that on a standardized test or a licensure test. Be aware of this. You have the luxury of asking questions now, so take advantage of it. Not if you won't always get an answer, but you should take it. That's part of test-taking strategy, something that we cover a lot in the MCAT class. If nothing else, I'm good at that. Okay, and making terrible grade. So the ileum, as you can see, is the longest, and then it ends there. So they have it in color, the purple, this particular shade of blue, this other kind of shade of reddish purple that's there covers the way, and you can see how neatly they are sandwiched in and sort of surrounded by the large intestine, with which we call the ascending colon, transverse colon that's somewhat cut away here, descending colon, and then the sigmoid because it's an S curve. Again, that same illustration demonstrating the bile duct. And the first thing to take note of are the circular grooves. And so this spiraling pattern, unlike other things, when we think of fluid, if we think of the bloodstream and we think of blood pulsing down after being ejected from the heart, going straight down. Yes, blood pressure involves pushing along the sides. But here, when you put something in the intestines, they don't go straight in. These circular plications spiral around, and that provides maximum contact. So they're effectively going in the grooves. At the Science Center years ago, haven't been there in forever, you used to have a thing where you put a quarter in at the top and you watch it spiral all the way down. Does that ring a bell with anybody? Maybe they still have it. My ex worked for many years as like a party presenter at the Science Center. That's where my son got acquainted with the Navy. He he started working at the Science Center on the Submarine Museum, and then he learned from the people who were on there. And for his senior project in high school, we went to Annapolis and interviewed the commander, who at that point was still alive, living in Annapolis. I was down there for a medical conference, and he came along with me. The rest is, as we say, history. So it's all right. Every family has to have one of those. Freaking nutcase. Okay. So the blood supply, again, mostly the superior mesenteric, a smidge of the inferior mesenteric. Hepatic portal vein, of course. Parasympathetic innervation and sympathetic innervation. They take turns depending on activity. And again, the length, and you're going to see these structural modifications. This is the nugget about how it can approximately, if you stretch it all out and look at the collective surface area with the villi and the microvilli, you would have something approximately the surface of a tennis court. Understand, as long as that gastrointestinal tract works, you have adequate contact. I was awaiting my first gastrointestinal surgery. I only could drink clear liquids, which meant my nutrition, other than water, not a lot of nutrition to the party, was those wonderful boosts and things like that. Okay, so I basically asked the gastrointestinal guy at St. Margaret's, even though I was in the hospital awaiting surgery, and he said, listen, as long as the GI tract works, you use it. So even me drinking 4 or 5 of those a day was better than any other, let's say, quote unquote, parenteral, what we call TPN, total parenteral nutrition, what they used to say, feeding somebody intravenously. The GI tract is more efficient at what it does. Just to give you an idea of how important it is. You don't need a lot because there's a lot of surface area. You have the circular folds, formerly called plica. A plica is a fold, circularis. Villi, finger-like projections about 1 millimeter. So they're like little nubs about the size of the tip of a pencil. Okay. And on those nubs are covered in their entirety, front, back, all around, with simple columnar cells, all with microvilli, as you will see, and that's the surface area. So the folds are about 1 centimeter deep, and the chyme spirals slowly through the lumen to facilitate the processing and the absorption. The villi, about 1 millimeter, and you'll see in the core of the villi, there's always a lymphatic capillary called the lacteal, surrounded by a capillary bed. Capillaries are arterioles and venules, to facilitate the absorption, which we cover a little bit more in the physiology part of the program. And then all of these cells have cytoplasmic extensions that appear as a brush border because it's fuzzy. But that fuzzy brush border contains all of those microvilli produce local enzymes. They're the final step. When you and I have carbohydrates, we break them down into disaccharides. Remember, maltose, sucrose, lactose, the 3 basic disaccharides. Hello, biochemistry people. Add a glucose to glucose, fructose, and the lactose, you get maltose, all the 3 disaccharides. We can't absorb them without those brush border enzymes. Someone who's lactose intolerant, as most babies are, okay, or someone as an adult is missing the, quote, lactase. To facilitate that means those sugars sort of mechanically pull along fluid and moisture and make things traverse the GI tract when you get somebody who has problems being lactose intolerant. Okay? So, and they play a role in both final carbs and also breaking down tri and dipeptides into amino acids. We get to that in physiology. So when we absorb, we absorb simple, small molecules, not big guys. So there's a good reason. They don't fit. Okay? So here you can see the pattern. You can see the grooves that are in there as they've depicted it pretty well here. The spiraling pattern. You can see the tiny nub-like villi, and you'll see them a little better. You can see the muscular layers, again, circular, then longitudinal. So all of those layers are there. There's a submucosa, etc. Here's the lacteal, lymphatic capillary surrounded by effectively an arterial capillary and venule and capillary surrounding it and delivering it here underneath and toward the submucosa or on the between that's there. And here you can see the brush border of mice. So this is all of these have microvilli on each one of these villi. So there is a ton of surface area. Here's a good close-up of the lacteal. The darker area, again, is the lymphatic capillary and then surrounded by tiny blood vessels. And then you can see, and these are, again, simple columnar with goblet cells. Mucus is pivotal, okay? Mucus, whenever you have columnar cells, respiratory and particularly respiratory with goblet cells and digestive, the mucus plays a pivotal role. That's why cystic fibrosis, the genetic disease, is so tragic, because it effectively, for lack of a better term, alters the mucus and makes it too sticky. So it clogs things up. And we're doing better with treating it, but that was really difficult. Maybe I told you my middle one was worked up for that because he had respiratory and digestive problems. Okay. That was way back, when he was, barely more than a year old. Oh, he spent a lot of time at children. So here are the microvilli. You can see that's there all along this enterocyte is what we call those basic cells. So just like the stomach has pits, these have indentation called crypts to distinguish it. So the enterocytes are the epithelium, simple columnar again, tight junctions again, because this is really elegantly pH controlled. Villi absorb nutrients and electrolytes. The crypts produce additional intestinal secretions, mixture of mucus that carries the chyme. Goblet cells, again, enteroendocrine cells, and the two, again, like gastrin and histamine and acetylcholine, where in the stomach here, the enterogastrones are cholecystokinases, always abbreviated CCK, and secrete, not CCR, which is, of course, Cretan's Clearwater Revival. No John Fogerty fans. You're excused. Just say it. Okay. See, if you're a Paul Revere and the Raiders fan, then you're really getting off. See, nobody heard of them. Okay. A long time ago in a galaxy far away. I told you my buddy managed a group that had one giant hit that you all hear. You hear it all the time. They're called Looking Glass. The name of the song was Brandy, which got a lot of airplay in the second Guardians of the Galaxy movie. A ton. That was their hit. And he managed them before they hit. They were a house band at Rutgers for a long time. He was at Rutgers probably starting in '68. Just pointing that out. I saw them in concert with the Beach Boys and the Kinks. Pretty good concert. Though we don't have a great memory of it, there was a lot of smoke in the air, so to speak. Just saying. Statute of limitations is expired. Just saying. Englishtown Raceway in New Jersey. So the enterogastrones are there. Paneth cells. These are they actively add to your defensive. We cover that in immune. Stem cells are super active. This is the area, more so than the stomach and the large intestine, that has the greatest amount of turnover. Okay, 2 to 4 days, complete new lining, continuously replaced. The malt or mucosa associated lymphoid tissue, their aggregates called Peyer's patches, a name you should remember. Great numbers as you get farther along, because what happens, bacteria, which are going to be used in the colon, kind of travel their way down there. You have enough protection against the bacteria. And frankly, there's a whole lot more good than bad bacteria when you think about probiotics, things like that. Okay, so there's a large amount of immunological stuff that's there. Okay, variety of glands, and again, it's all pH. Stomach, acid. Small intestine, alkaline. So they neutralize one another. So the mucus is alkaline in the stomach because the secretions are acidic. And then it continues to be more alkaline mucus in case there's any residual acidity. So when we start looking into physiology, pH is a major player in activation. And this is the biggest single area targeted by chemotherapy, and for that matter, radiation therapy, are the intestinal crypts. They are always affected. That's why there's always diarrhea, why there's always difficulty with digestion. It's a big, big problem. Nausea, vomiting, diarrhea, continually. I had so many patients when I was in practice, because up in that area, we had a lot of industrial stuff in the days long before they had a lot of controls via OSHA. And I mean, I had so many patients being treated for cancer. I can't be. And I mean, they would just they'd start it and they say, hey, you're going to have vomiting and diarrhea and all that type. It's just awful. Most a lot of good people that way. So the intestinal juices are continuous, and when we go into the physiology, even those little bits of fluid stretch, and those stretch receptors trigger responses that start gastric motility or intestinal motility. It's hyperosmolar. That plays a role. The acidity plays a role. Those are so important. So the major stimulus for production is the hypertonic or acidic chyme. Okay. And again, those juices are alkaline and isotonic with blood plasma, water, mucus, a variety of other things that we'll get to. And so, and we'll go through all of this. Is again much more physiological, the regulation thereof, and again the way it moves. Segmentation much more common in the small intestine. So again, it slows down the processing because it's not shooting through; it's traveling circularly and spirally, and it's constantly moving back and forth, back and forth, back and forth. It's like the agitator in the washing machine. Agitator, washing machine. I like ours because it doesn't have the big thing in the middle anymore. Love that. And there's a variety of reflexes. We get into peristalsis. There's a hormone called motilin down the road that as stuff starts to get farther down, it's almost like the signal says, hey, we're filling up, move it along. Then they have a fancy name called migrating motor complexes. And so the meal remnants, which you're not going to be utilizing, bacteria, cellular debris. And as you can see, from the duodenum to the ileum in a couple of hours. So you're looking between stomach and small intestine and then into the large intestine, 8, 10, 12 hours totally, more or less. And then it reaches the ileocecal sphincter. Again, small amounts of chyme. Okay, and what there is there are reflexes. So, okay, something goes in your stomach, and you may have noticed this, that when you eat something, sometimes you get that urge you have to go. That's the gastroileal reflex. It's almost like, hey, we have incoming in the stomach. We may need some room. I don't want to be gross about it. Hey, You are what you eat. Okay, so it increases the motility of the ileum, effectively of what happens. And obviously there's a flap-like arrangement so it doesn't regurgitate. And there you are, on to the large intestine. Nice seeing the large intestine. The large intestine is not as complex. It does not have all those adaptations. It is non-essential. You can do without it. So a lot of times, and this is something as folks get older, they're always insisting after age 50 or so, whatever the current guidelines are, to have colonoscopies. How many commercials do you see on TV for those Cologuard? So they're checking for gastric bleeding. And indeed, if there's gastric bleeding, you start to look for things called polyps. Little rising areas, growths would be a good enough term, non-cancerous, at least to start, that tend to produce areas of irritation, maybe localized bleeding. And so when someone sees blood in the stool, it's not, typically we don't look for red. That's more indicative of something acute or hemorrhoids, as opposed for black or tarry stools, because the blood has started to alter and started to break down. And we'll study this in the blood. So think of a bruise that you get as it begins to discolor over time. When you get a black and blue mark, how it changes colors. Well, the blood's doing the same thing. It's oxidizing. And so that's what you're identifying when you're doing those tests. And if that's positive, then they'll typically want to do a colonoscopy. So and there's a whole lot of things that happen. And again, these are probably more often associated with aging populations. The lady who was my first accountant when I was in practice, about 1980, I got to know her in the early 80s. And younger than I, and her husband was a couple of years older than her. He died of gastrointestinal cancer before the age of 30. So this is not something that's strictly associated with older folks. That's the point I'm making. Now, I've lost contact with her. She was here in Pittsburgh for a long, very sad. So the large intestine, 3 external features that identify it. It's got 3 bands of smooth muscle, and they called it the tinea coli. Effectively, they thought it was like a tendon of the colon, but what it does is that those bands hold that characteristic up, across, down shape. Haustra, because rather than being the small intestine, which is continuous, it has segments, and the segments are kind of large, and so haustrum is the singular, haustra, and the tone of the tinea coli. And it has what are called epiploic appendages, which are like fatty teardrop items that you can see. And if we, at the end of the term, I'm thinking we might do a mammalian dissection. Like they typically do a fetal pig. Can't do the cat because my cats would never forget. What?
I mean, we can do it.
I can't do it. I can't go home and say, "Oh, hi, Cloud. Saw your Uncle Joe. He's dead." He's a kid. He's our kitty. Cloud and Tux can't do that. Can't do that. We're out raking leaves. We had like 2 cans and 10 bags of leaves. And the cat's crossing the street. What the?
Oh. Yeah.
What in heaven's name are you doing crossing the street? I yell at the cat. And he mews indignantly. We think he speaks in cat. The cecum, again, is the first haustrum that's there. It's got its own name. It's identifiable because of the worm-like structure that protrudes, pointing downward and somewhat centrally, known forevermore as the appendix, or vermiform appendix. And the current theory is it stores bacteria to reseed the gut with good bacteria in cases of diarrhea, vomiting, colitis. And unfortunately, the twisted nature of it, and it does twist, you can see when you have scrubbed in enough of these being removed, that it really has that sort of spirally look. Stuff gets trapped. The colon, and most of them are retroperitoneal. The only ones that are not on the back wall are the transverse and the sigmoid. They have more mobility. Ascending travels up along the right side, and it flexes to form the transverse at what's called the right colonic or hepatic flexure, because it's by the liver. The transverse goes across, then it goes down. That's the splenic or left colic flexure, and then it eventually forms the sigmoid because of its S-curve shape, and then it leads into a straight unit called the rectum, which has basically valvular-like structures, that are under internal control, non-active control. So they're smooth muscle, and then eventually we get skeletal muscle with the external sphincter that we control. So, and then the last segment, as it effectively, now we get to the transition to stratified squamous non-keratinizing, because now you have abrasive fecal material, and it changes pretty much abruptly from anal canal and into the anal area, from the sigmoid and rectum. And so you have internal sphincters, and again, the external is voluntary control. You always see this illustration. Here's the ileocecal valve. You can see the appendix, mesentery, but you notice the way it points. So that's why a lot of times clinically, when someone has acute appendicitis, it points toward the umbilicus. And so, and we have it, and this is a very interesting phenomenon called rebound. So you can push, palpate, and it'll hurt. But when you release it like that, the rebound tenderness, people will just go, oh, saying unpleasant things to you. Like, why did you do that? Not using those words. So there it is. There's the cecum. You'll see, like when we do a dissection, the cecum is quite large. It's almost like a second stomach in rodents when you do in that. Here are the Taenia coli, the bands that go around. They're showing you a couple of them, obviously. Here are the epiploic appendages. Each of these is the individual haustrum, collectively haustra, all the mesentery that are there. Those veins are widened, flattened. That's where hemorrhoids kind of come from. And there's a variety of reasons for that. Aging, bowel habits, anal intercourse, things like that play a role with regard to that. And again, just a variety of pictures kind of showing you how it sort of eventually the sigmoid colon will sort of centralize. And sort of, remember, these are on the outside and they finally come in. Here's the start. And then here you can see that sort of S curve going from more toward the outside, the periphery, in centrally, and so on. And it's a pretty good view to give you an idea of all the mesenteric structures and how they're sort of held in place. Again, more common in adolescents, interestingly enough. And when you see necrotic, it's extraordinarily painful. The absolute worst case that we saw, the patient was fine because when the appendix burst, it buried itself retroperitoneal. So I was working with a surgeon, and we're up doing the procedure, and he goes, something's going on because this guy, we're just not seeing the sign. And on the posterior, the internal wall, there was a fluctuant area, and he incised it and outshot more pus than you can imagine. And the smell was horrible. It's an absolutely true story. So we were working in the OR. When you do a case in the operating room, you always do dirty cases at the end. We did not know this was infection. Once you do a dirty case, it kills the operating room. You have to do a very comprehensive. So all they said, 5 trillion men buried here. We incised it, the smell. So when it became infected, the nurse was like the second, not head nurse, but the second head nurse. They put a towel with disinfectant in the door. And so we finished the surgery, I was doing fine. And she goes, no, you can't leave. What do you mean you can't leave? She goes, you can leave with your clothes on. Well, a lot of us doing surgery don't wear a whole lot under. So we both walked out with, say, this underwear, bottoms. Some people would have had to walk out in their proverbial birthday suit. She wanted everything. True story. And I was not even, I was, let's say, not a whole lot less skeleton than I am now. So, be careful. Make sure you have some garments on if you're in the office. Yeah, if you're going on, you never can tell when you're wearing clothes. Absolutely true story. So everything went off. You know, we had shoes on, but most time in the operating room, you have like a pair of shoes that you wear, like an old comfortable pair of shoes. People wear clogs, stuff like that. No, I wore sneakers, but you just, it's very interesting. Interesting. Not a whole lot to say. Simple columnar. Once it gets to the anal area, stratified squamous. Doesn't have all those adaptions. Columns are there, etc. Same illustration you saw before. Thousands of bacteria outnumbering our own cells easily, 10 to 1. And they play such a significant role. We'll get to that basically in the physiological program. A lot of that, there's a whole lot of interest in manipulating gut bacteria. I mean, just when you see all the things that have probiotics in them, it's really significant. And I think that's really everything that, because all the rest of this is physiology, as I believe. So that's really the anatomical part of the program to complete here. Now, where we go from here. So anatomy-wise, the next things that we go to are, I'll show you. I do not have a handout. This is the last of the handouts that I have. But I did want to give this to you. Yeah, I probably sent that to them again. I do it all the time. Did you get that test thing, or did I send it to the other people? Easily could have sent it to them. So we're in 4, and that's where I'm putting stuff. Respiratory, digestive. I have a digestive. Now we get here. We get urinary, and it's almost all on A. There's a smidgen on B. We get repro, which is male A, female B, and then we're done. What I have under that afterwards here is this. So I'm anticipating, I was telling Dr. Hilwig that earlier today, that we'll probably do a little bit of, my anticipation is we'll do, let me get this. Make you look good here. Is if you'll submit to me some topics, because with Dr. Maurer, he doesn't do the clinical aspect of micro, which I think is really important to understand. And it's one of the things I'm good at. Not a lot. So this is what I just want to introduce what we're going into. Touched on it a little earlier today about what the kidney does. And, you know, there's a lot of things there, but to me, excreting metabolic waste, number 1 on the hit parade. Okay. Physiology, we'll talk about next term, ions, acid-base balance. But for our purposes now, it's mostly about metabolic waste and other functions that are there. So you're going to see a rather elaborate look anatomically, but the complexity is much more when we start to get in here, and we'll see this. So there is a kidney, and probably by next week, We can also, maybe we have a couple of kidneys. You don't get as much out of it, but you can see they're called pyramids for a reason, these pyramidal structures. And it plays a really important role in understanding the pattern of blood flow. And this, to me, the most interesting part about it is how the kidney does its magic. Okay. It's the only system that I know of anywhere in the body where we get arterial blood going through a capillary bed and coming out as arterial blood. Normally, that's where the exchange of oxygen and carbon dioxide. But what energizes that system, everybody, pressure. That's why the kidneys are a high pressure filter. They don't start the blood that comes out once the filtrate is made, is processed. When we process the filtrate, claim what we want, expel what we don't want, adjust all the values, and create the urine, that's where energy is required. And you're going to see there's a series of capillary beds called peritubular and vasorecta that play an important role in this. Again, that's more physiology, but it's important to understand. So we'll leave it there for today. You're done. Nice seeing you. Hand back those things if you don't mind. You can always come and look at them. I'm happy to have you do that. Not ecstatic, but happy.